So we spent the last lecture talking about mostly plain film techniques or X-ray techniques and a little bit of radiobiology and the risks associated with using radiation. This time what we're going to talk about is advanced imaging techniques, and we're going to start with CT, MDCT or multi-detector computed tomography. And in the olden days it used to be 2D in that it's a 3D imaging, but it used to be that you have an X-ray tube located on a ring of detectors, and that would rotate once and then the table would feed in, and rotate again and then the table would feed in, and it would be done like that. So a head scan would take a couple of minutes, a chest abdo pelvis would take 5 or 6 minutes. Nowadays, with the advent of slip ring technology, it means that an X-ray tube can spin around 360 degrees and have detectors around those 360 degrees. And through little, very small wire brushes and very high technology, we can get a 3D volume without what's up on the screen there, the interslice delay. So you can do a head scan in mere seconds and do a chest abdo pelvis in once again about 10 or 15, less than 10 or 15 seconds. And that's the advantage of this is the fact that we can introduce that contrast media that I was talking about in the previous lecture and get that really crisply on the screen. We can do multi-phases, so we can do the arterial phase of the contrast media, in the case of the liver, the portal venous, and then the venous phase. So we can actually be a lot more creative about what sorts of pathologies we're trying to detect, and be a lot more creative about the sequences that we use to highlight any pathologies. Now, how does all of this work? This is one of our machines that we've opened up. The engineers have helped me. We've opened it up and we'll show you. Along the bottom you can see the bank of detectors, or a bank of detectors on the bottom, and there's an X-ray tube at the top. And what happens is that spins around the patient on this slip ring technology. It generates around about depending on how fast it rotates, it can generate around about 30 Gs of force. So these are generating enormous amounts of force, and I know you can't appreciate it from the image here, but they're quite noisy. There's a piece of paper at the bottom that's on the table. Luckily it didn't get sucked into the machine, or else I think all of us would be looking for new jobs. But you can see quite clearly that that X-ray tube and bank of detectors, that massive amount of equipment is spinning extremely fast. In this case with this, what we call a vision, it's called an Aquilian vision. The tube is rotating once in 0.275 of a second. So that's a massive speed and massive amount of technology that goes into that. These machines, by the way, a top-end CT machine retails for around about $1.8 million. I'm not sure. There are machines that come down and down in that, but $1.5 million is not unheard of in terms of CT scanners. The versatility that comes with being able to image the patient in their entirety can't be understated, and a lot of work is going on presently in developing up algorithms, techniques, so that you can do what I've shown you up on the screen here. You can look at the soft tissues, looking at the architecture of the muscular system, and then the bone architecture in the one acquisition. So this patient's gone through the scanner once, and by virtue of the algorithms that have been applied to that three-dimensional data, you get the versatility of that image in terms of not being able to scan, not being required to scan the patient twice, but look at both the soft and hard tissue characteristics. If we look at this one, this is a CT, a slightly different CT. Some of you might have had this performed before, what's called a coned beam CT. It's used for dental architecture. A lot of places are using this now for planning dental, very expensive dental treatments, the extraction of teeth and the realignment of teeth with braces. It's also used for trying to position for implants, dental implants and all of that sort of stuff. This is once again a technology, a CT technology, where one acquisition. Patient's gone through the machine. This acquisition takes around about 20 seconds. Different technology to the $1.5 million one. These machines are a couple of $100,000, and you can see the data, which is recorded in what we call DICOM, or Digital Imaging Communications in Medicine, a specific format for medical images, and it's fed into a software. This one's called Dolphin software that allows you to manipulate the images and look at them from various standpoints. It's a powerful technology, and I often refer to this as imaging for juries, and I don't make that claim lightly. It's about making imaging, medical imaging, which is seen as being high-tech, very highfalutin. It's bringing it to the same degree as you whipping out your iPhone and taking an image as well, and being able to manipulate those images and show them in formats that actually make meaning to a person having a look at them. The other advantage, I was talking in the introduction about being able not just to look at qualitative changes, like before even with the dental images, we saw the dentition, we saw the soft tissues of the face, and we saw the hard tissues of both the dentition and the mandible and maxilla. But what we can also do with CT technology is we can look at things from a quantitative viewpoint. And as you can see on the graph, the right-hand side, what I've done here is looked at the volumetric bone mineral density, which is a measure of the ability of bone to withstand forces that may cause fracture, and looked at that in a population from 15 to about 95 years of age, and look at the changes that occurs. As you know, the older we get, the more bone density we lose. And the ability to be able to do this with CT has been quite powerful, and there are a lot of research interests and a lot of companies presently working on ways to utilise quantitative data from CT, MR, ultrasound in various ways to both monitor disease progression and to also look at treatment efficacy as well. It's a very, very powerful way of measuring these sorts of changes within a single patient and within populations as well. And I just wanted to show you this one. Normally with CT, we look at images in static, or looking at them in static ways. The advances that are currently coming with CT technologies is that we can actually get the patient to do an action, to move. In this case, this patient, the radio-ulnar joint, move within the CT scanner and produce images that not only show the anatomical position, the anatomy of the patient, but also show the functionality in 4D, and that has been a very powerful force in CT technology. Mainly, we use it in the distal or in joints like the wrist and the ankle, which because naturally we apply radiation for a little bit longer while the patient's doing their action within the scanner itself, and so that does require a little bit more radiation. So a lot of the work to start off with has started on the wrist and the elbow. A little bit of shoulder work, it's always been done in the knee and ankle. And this will be a powerful force too, as we develop up algorithms that allow us to do this with using a lot less radiation, much less than what we use now. This sort of field, this dynamic imaging, is going to go along in leaps and bounds. It really will. We can also use CT imaging to image flow. Like I said to you before, we can inject contrast media in the upper left-hand side. You can see the cardiac vessels of the myocardium, so you can see the left and right coronary vessels perfusing the myocardium. We can also do perfusion imaging, so we can take snapshots of flow over a period of time. In the bottom right-hand side, you can see that in the example of a stroke patient. So we can see that the flow and the position of the infarct, or the area that isn't being perfused properly. And this is a growing area in medical imaging as well, is being able to image flow, not just flow from a static perspective, or not just flow in the as you can see in the heart there, but also flow about the perfusion of muscle, perfusion of organs. And this will continue to develop over the next little while as well. These are some images from forensics. A lot of the forensic institutions around, especially Australia and Europe, are currently using CT. A little bit of MR, but CT. They'll image all of their decedents that come through. These are people that have died in a condition where a doctor is unable to or unwilling to sign a death certificate, or where they've died in unusual circumstances or unexplained circumstances. This is an example of a car crash. You can see the femur on the left-hand side, so a rapid deceleration injury where the dashboards come up and smash their femur, and the fracture of C2, the dens in the neck on the right-hand side. It's been particularly useful, I think. The use of medical imaging in forensic applications has kind of been a bit slow to take up. A lot of work is currently being done on even using that contrast media, even though there's no flow, obviously, in a patient or person who's died. But using contrast media to show things like heart attacks and things that are a lot more subtle than that as well in decedents, and that's a rapidly growing side of both forensics and research. Next we have magnetic resonance imaging, or MRI. I've got some images up on the screen there of accidents that happen. Most of the equipment that we use here in Australia is magnets that are permanently on. And there are accidents. Any of you who have had an MRI scan will know that you go through quite a comprehensive questionnaire before you go into the room, just to make sure that you don't have any implants, or you've not got anything in your pockets or anything in your hair or whatever that's going to create a problem with the MR. And you can see quite clearly that the power of the magnet in attracting things like cleaners and chairs and arc welding equipment in the images there. And if you do a search for MR accidents, you'll see a lot of examples. The only way you get these things off, because you're using a magnet here with 20 or 30,000 times the strength of the Earth's magnetic pull, the only way you're going to get these things off is with a big ratchet and try to sort of pull it off. And it's quite a dangerous thing to occur. I just bring this up because there are people who can't go into a magnet or can't have an MRI scan. There is no real contraindication for a CT or plain films or ultrasound, but MR is one of the imaging tools that there is a contraindication to go in. Even there was a little while ago, they used to use black tattoo ink that they used to put in as eyeliner, so they'd tattoo the eyeliner in, and that ink that they used for that particular scan had a lot of ferrous oxide in it, and iron is heats up within the magnet as the RF pulses are put in. The way an MR works is, I'll show the next slide. The way the MR works, if you look at the bottom of the slide there, all of your hydrogen atoms within your body are all just sort of spinning around doing their usual thing. When we put you into an MRI, your hydrogen atoms align with the magnetic field. We put in an RF pulse and we flip them around, and as they relax back, they give off a signal, and that's what we use to create an MR image. That's a very, very, very simplistic overview of what goes on in MR. It's quite a complex piece of technology, but it gives you an idea about the power of MR as an imaging tool, and the fact that using that very, very high strength magnetic field and flipping hydrogen protons, it actually has a little bit of danger associated with it. With the RF, as I said before, if you put a metallic material inside, not only does it create artifacts, but it can heat up. So we need to be careful about patients that have just had surgery, patients with tattoos with high levels of iron content or ferric oxide content within them. So it's not a straightforward procedure, and any of you who have had an MR, as I said before, will know that there's a bit of a process that goes into having an MR scan. But you can see up on the screen there in the top, there's T1, T2, PD stands for proton density, FS stands for fat sat, or fat saturation. And what happens when your hydrogen protons, as they spin around and they flicked over with the application of an RF pulse and relax back, they'll give off signals. If the hydrogen proton is associated with carbon, it's fat, and with oxygen, it's water. And those two, fat and water, because of their different hydrogen linking properties, will give off different signals. So we're able to alter those signals and give different imaging characteristics or different qualities to those imaging characteristics. And that's what I've shown up on the screen. The last one is short T1 inversion recovery, just a specialised sequence. But you can see the water is very much highlighted in the latter two images, the fat saturated images, so you're highlighting water, whereas in the T1 you can see it's a very anatomical image. You can see the fat quite nicely. If you look at the front of the anterior of the patella itself, you can see the convolutions of the fat within that patient's knee as well. So it's a extremely powerful imaging technique. It's got a lot of different sequences that can be used to enhance the different characteristics of those spin profiles, but it's not for everyone. I'll show you a couple of case studies. You can see this is a bodybuilder. He had an 18-month history of medial knee pain, and he had some cortisone injections that kind of helped, but only in the short term. And his MRI shows on the right-hand side, you can see a torn posterior horn of his medial meniscus. You can see in nature, if you look at the anterior horn, which doesn't look particularly well intact either, but you can see that it is crisp, the borders are crisp, just like we were looking at the plain films, and it's a relatively consistent quality in terms of the colour of it throughout. And you see the big line where the yellow arrow's pointing to, that's the tear within the meniscus itself. It should be consistent across all of it. It should have nice smooth borders, and it doesn't in this particular patient. So it's quite quite powerful in terms of imaging. This is another person with a recurrent shoulder dislocation. You can see a Hill-Sachs defect. You can see the humeral head itself. Once again, it should be consistent. There are differences within the trabeculae. Of course, there are vessels that feed as well that will show up. But you can see, especially on the right-hand side, near the Bankart lesion, you can see the inconsistencies within the bone itself. They're bone bruises, and interestingly enough, MRI is one of the only technologies where we can actually see bone bone bruises in situ. A lot of the footballers, when MR first came on the scene, and quite a number of years ago, a few decades ago now, they had people with bone bruises that they didn't quite know how long bone bruises took to heal. They didn't quite know about them. They knew they existed, but they didn't know very much about them until MR came on the scene. This is an image of an anterior cruciate and a posterior cruciate. If you have a look at the image on the left-hand side, the anterior cruciate is that black line. It's a very thin, spindly thing that's supposed to connect all the way up to the femur, but it doesn't in this particular case. The posterior cruciate on the right-hand side, it's a thicker bundle of fibres, and often you'll hear people talk about snapping and popping, and they can actually hear these go on the field, and you've probably heard that story in a number of your patients and maybe in your colleagues that have played this, hopefully not you, but you can actually hear these ligaments go out in the field themselves, but they do have different characteristics. You can see the different characteristics. The anterior cruciate's very fine, very straight structure, and the posterior cruciate's a big, thick band. A bit more, I liken it a bit more to like the Achilles tendon on the insert, very thick band, very fibrous, very tough. and they look slightly different. You can see that because they don't have much water in them and no fat, of course, because they're ligaments, they should be nice and black on these images, but these ones where they've snapped, they're not black. They've got signal throughout. There's a lot of inconsistency in both anterior and posterior cruciate ligaments are gone. This is a baseball player who got hit with the bat in the shin, and you can see what I was talking about before. If you look at the image on the left-hand side, the femur looks nice and smooth. You can see the convolutions of the trabecular patterning throughout the distal femur, but looks nice, looks smooth. If you look at the femur, you can see the tibial plateau fracture, and you can see that huge bone bruise within the tibia itself underneath that fracture and that bone bruise. That middle image, the STIR image, is a little bit fuzzy because the patient moved throughout the scan. That's the thing too with CT images I was talking to you about, a 10-second scan or a head scan. We can do a head scan in about a second or so. We can do a volumetric head scan in about a second or so, very fast. MRI studies with newer technologies like newer sequences like compressed sensing, if you want to look that up. You can do scans in a lot quicker time, but they're still, a minute and a half for a scan rather than with MR where you're talking in seconds. So it is difficult. One of the things about having these scans done is to try and get the patient positioned in such a way that they can keep nice and still. And that's often quite difficult with these patients that have significant pathology and are in a bit of pain. This is a jogger with ankle swelling. You can see the Achilles tendon. It should be nice and black like it is proximally, and then you can see that as you go further and further distally where the arrow is, that the signal in the Achilles tendon is getting higher and higher. That's because you've got blood and inflammatory exudate products that are creating that signal. There's a full thickness tendinitis of the Achilles tendon at the site of attachment to the calcaneum. So MR is, you look at the medial collateral, the anterior cruciate, posterior, all the way across, and including the patella tendon and the femoral and tibial bones. You can see that MR is a powerful tool for musculoskeletal, especially sports injury type applications, and that's why it's used extensively. We have a Canon Medical support Manchester United, FC Barcelona, and a few of the other teams as well. And they've developed quite an interest in using MR, mainly because of the fact that it doesn't use ionising radiation. But they've developed quite the research interest in looking for things like occult cardiac problems. You've probably heard of sports people that go out and have arrhythmia and other sorts of cardiac conductive problems and unfortunately pass away in the middle of exercise. There's a fair bit of research going on in looking for and screening for those sorts of problems in elite athletes or kids that are working towards becoming elite athletes. And there's a lot of interest in developing up techniques that are able to show the efficacy of treatments, especially in sports people, I guess, where it's okay if you and I get injured, it's okay to be out of, the gym for 4 weeks or something, we're just not happy about it, but we'll live with it. It costs a lot of money for these guys to be away from their sporting activity for any amount of time, and there's a lot of research going on using MR and ultrasound, the non-ionising radiation techniques to try and work out ways of monitoring the efficacy of certain treatments and to try and maximise the treatment efficacy and shorten the amount of time that they're out of the field. And so ultrasound, again, it's a point of care, what we call a point of care option, which means an MR unit needs to have a room that's shielded away from extraneous metals, and RF interference. So they have outside of them what's called a Faraday cage. So, RF can't get into the room and disrupt that flipping of the hydrogen protons. It's certainly a purpose-built room. There are trucks that go around in the United States and perform, and they have set up areas where they can do MR, but it's not what you would truly call point of care options. But ultrasound, you've all seen them before. You wheel them into the room and use them straight away, and they're very, very effective. I was actually having a chat to some of the doctors from some of the elite sports clubs, and they don't see their players. They don't actually talk to their players without, an ultrasound probe in their hand, sort of going over their shoulder or their knee or whatever. That it's something that is so important to get an idea about what it is that's going on. We, of course, as regular human beings in the general population, don't get our doctors to, be that closely linked to our musculoskeletal health, but certainly ultrasound has a big place to play, and there are lots of different technologies coming on the scene now to look at microvascular intrusions into ligaments and trying to find ligaments that are damaged, like that Achilles tendon, but maybe even a bit earlier than that. So looking at tendons and ligaments before they actually rupture or before they get into significant disease. And ultrasound and the technology, the engineering behind ultrasound is becoming increasingly used for that. And you see down the bottom, ultrasound's obviously used for gestational imaging as well. Very popular for that. And I'll finish off, because I talked about point of care imaging. I think that's one of the things that will change a lot as we go further and further into imaging and developing up in imaging, is the software that can be used on the images that are acquired, but also that point of care being able to do, as you can see up on the screen here, this is the cone beam, the dental unit that I was talking about before, something that costs $200,000 rather than $1 million. It's able to be placed into a room. It's purpose-built. This is purpose-built CT scanner for dental applications, so it's not for doing, knees or shoulders or chests or heads or anything like that. It's purpose-built for that. I think the future probably holds much more of point of care applications, and much more in terms of being able to qualitatively and quantitatively assess images. I guess I wanted to finish off just by saying that things work better when they're in the right place, and medical imaging is that. It's about balancing. Go back to what I said at the start. Is balancing, what do I need to know from this examination? What do I need to know in order to change the patient? There's no use doing an imaging procedure if it's not going to change the patient management. It has to change the patient. It has to have an impact, whether that's even a decision not to treat, that's fine too, but it has to have an impact. Otherwise it's a waste of time, it's a waste of money, and it's a waste of the stress and strain. When you think about medical imaging, there was a study done quite some time ago now, talking to patients, and what was it that affected their psyche before that? What was the thing that they were most worried about? And most of them were worried about the results, about getting cancer or having some sort of deleterious health condition or some sort of disease mentioned in relation to them. And so our medical imaging needs to balance those needs, the needs of the patient to find out that they're okay, the needs of the doctor to say, okay, well, this is how I'm going to treat this condition, and the needs of the population in general in terms of delivering, as I said before, you can't just deliver radiation without any consideration of the effects. Obviously, if you're a young person, you worry more about it than if you're a person who's older. And with MRI, you need to worry about the other concerns that I was talking about before, implants. And a lot of the implants that are being introduced into patients obviously are MR compatible nowadays, many more of them are. But there are also a lot of people around in the population that have had implants that have been installed a long time ago, and they're not compatible with MR. And also MR is quite a claustrophobic environment, and not all patients are up to spending time in that environment. It's also very, very loud, and there have been cases where people who have been subjected to war and those sorts of activities find MR and the clack, clack, clack of MR quite confronting. So, and so, as I say, it's about balancing up all of those concerns and all of those outcomes in order to make the right decision. So thanks very much for your time, and good luck.